Good morning, good evening, good afternoon. I'm here back again on Global Implantology Summit uh, with my dear friend Dr. Mohsin. I have hosted him recently, a few months back, for HP's technique, but here he's back again for us and for the whole world, and he'll be talking on peri-implant soft tissue engineering, which is the most important subject. And as last time I hosted uh, Dr. Otto Zur, he said that 50% of the implants being placed all around the world are subjected to peri-implantitis. So that means a kind of failure, and when your implant placed is going into peri-implantitis situation, that's not bad. So we have to think about building up the soft tissue, the peri-implant soft tissue, if you want to place implant in a more predictable way. So here we have Dr. Mohsin from France. He's a very good friend of mine, and I met him almost 7 years back because last time when I was here hosting Dr. Henry Diederichs, we met at his place in Luxembourg for his first course, and I'm here back again. And let me tell you one more thing that I'm going undergoing with a lot of stress these days because I lost my workplace. But still, because I promised and I wanted to host him, he's a great friend of mine. So I'm back here again. Even after that, the whole day I was shifting my clinic. And here I would like to say a few words about Dr. Mohsen. I would like to introduce him before he starts his presentation. Let me tell you about Dr. Mohsen. He did his DDS from Montpellier University, and then he has oral surgery degree from Montpellier University, and then post graduation in periodontology, implantology, and oral surgery from New York University. Then he got his university diploma in oral and maxillofacial surgery from Toulouse University, and he did his Bachelor of Maxillofacial and Oral Expertise from Montpellier University, then three-dimensional medical imaging diploma from Toulouse University. He has his master's in advanced oral surgery from Paris University. He did his diplomate of pre-implant bone grafting from Zimmer Institute. He has a university diploma of occlusodontic studies from Cisco. He's the member of the scientific committee of International Group of Oral Rehabilitation, IGOR, and he's the member of French Society of Biomaterials and Implant System, SFBSI. He has a diplomate, which is very close to my heart, the Academy by our dear Professor Dong Seok Son. So he had got his diplomate of World Academy of Ultrasonic and Piezoelectrical Bone Surgery, WOPS. I am the Southeast Asia president for that, so that is very close to my heart. And then he's the founder president of International Academy for Implantology and Oral Surgery, IAIOS. He is an international speaker, and he has his own practice in France. So I won't take much time because he has something wonderful to present before us. He has very limited time, 1 hour. So here I am presenting Dr. Mohsin to all of you. Dr. Mohsin.
Thank you, my friend. Thank you, Dr. Sandeep. First of all, I want to thank Dr. Kenya and you, Sandeep, to invite me to this this event. I I am very happy to share with you uh, my experience and knowledge about peri-implant soft tissue. I am from Lyon, greeting from Lyon. This city is very beautiful, and I invite you to come here to visit this beautiful city. The When we want to place implant in the condition, we have to preserve certain protocol to preserve the good health of the tissue, the hard tissue, and the soft tissue in the area of implantation. There are some imperatives for implantology in the aesthetic zone, especially any prosthetic restoration, whether on natural tooth or on implant, must perfectly integrate in its biological environment, represented by the marginal soft tissue for a natural aesthetic rendering. The appearance of peri-implant soft tissue is of paramount importance in the aesthetic rendering of the restoration, serving as a recipient bed from which emerges the ceramic. The peri-implant tissue thickness guarantees this solidity and thus their stability over time in the three dimension of the space. The papilla, as well as the alignment of the colors, are criteria to master in order to obtain an harmonious smile, especially when the smile line is high and visible. The concept of the biological web of the gingiva around natural teeth is equally applicable to the peri-implant soft tissue. And when we know that the osseointegration of the implant is now mastered, the long-term stability of surrounding soft tissue seems to depend on their epithelial and conjunctive attachment to the titanium surface. If we want to compare between natural teeth and implant, you have to know something in the biology. The natural teeth has some group of fibers, supragingival fiber groups, as here the sacral fiber groups in the papilla, the odontogingival groups in contact with the cement of the root, and the alveolo-gingival fibers on the crest of the bone, and the periosteogingival. All these fibers are interconnected between them to ensure the stability of the tooth and the stability of the soft tissue around the tooth. The soft tissue around the teeth and the implant show many common clinical and histological factors, but there are many differences between them. In peri-implant environment, there are absence of cement layer or ligament on the implant surface. The orientation and attachment of connective tissue fibers are different, and they are not tangential attachments and nor Sharpe fibers. The composition of the connective tissue, we can find a high collagen content and a small number of fibroblasts around the implant. The arrangement of the bundle of the collagen fibers, and they are not enough vascularization, since the implant does not have periodontal vessels. That's why the resulting conjunctive grafts around the implant are always more delicate to carry out. In this picture, we can compare between tooth and implant. We have a long junction epithelium attachment for 2 millimeters of height. It will be more high in implant environment than the tooth environment. The biological width refer to the height of the gingiva of peri-implant mucosal attachment apparatus around a normal tooth or implant, respectively. They are also an area of connective tissue for 1 to 1.5 millimeters of height. During the healing, you have a protective barrier formed around the dental implant. The soft tissue integration is the consequence of the creation of epithelial and connective tissue. The soft tissue cells the bone surface from microbial exchanges occurring in the oral cavity. That's why in this picture you can see easily the formation of circular fiber around the implant in order to have a good healing for the soft tissue around this implant. You have to preserve the peri-implant soft tissue barrier. In the case of natural teeth, the mucosal barrier is a biological width around the natural teeth. It's comparable to implant component is composite with sulcus and junctional epithelium and a connective interface. You have you can compare here the sulcus between natural teeth and implant. The epithelial portion adheres similarly to the tooth cementum and epithelium component through the various adhesive proteins. In natural teeth, the fibers ensure a tight seal between the soft tissue and tooth and contribute mechanically to strengthening the barrier from bacterial infiltration or other foreign body penetration. And on the implant surface, the collagen fiber adhere parallel and circumferentially on the transgingival region of abutment surfaces, resulting in a weaker connective interface. But we have to know that there are many characteristics of peri-implant mucosa. There are a difference between natural mucosa around the natural implant and peri-implant mucosa. This mucosa is a scar tissue with a mediocre defense against exogenous irritation, a lower ability to encapsulate a lesion associated with the plate. And when we want to restore peri-implant tissue, we have to know what kind of different type of architecture and defect we have before implanting. We have to know what suitable technique to manage hard tissue first and implanting and to manage soft tissue in second time. As you know, we have different kind of architecture on the mouth. We have a fine and scalloped gingiva or a straight and thick gingiva. And the architecture is determined by the anatomy of the teeth, the width of the proximal faces, and drawing of the enamel semantic junction, the position and the size of interdental contact surfaces. We have to class different defects in our area for implantation from the Palachi classification. I propose you this classification because it's easy to give a difference between class 1 to class 4 in vertical direction, between intact papilla to missed papilla, or on a horizontal direction between intact vestibular tissue to extreme loss of vestibular tissue. All these combination of these different classes are possible, and the practitioner will make a therapeutic decision according to his understanding of the problem. The aim is to get as close as possible to have a class 1A. In natural teeth, we have an area between the apical limit of junction epithelium and the bone crest. This zone is the same. We have the same thing in the implant environment. We are between the apical limit of junction epithelium and the bone crest. This zone is not vascularized. You have to manage this connective zone for in order to preserve the perennity of the implant in his seat. Ultimately, when we have to give in reproducible surgery, we have to place our implant in the good position, in ideal position, into the bone, and place the pillar and the crown in the ideal position. In per-operative time, we have to determine the quality of the gingiva. The biotype is important to have a good biotype around our implant to preserve the implant in his seat for a long time. When we have a thin biotype, you have to change this biotype in thick biotype. That's why we have to give surgeries of soft tissue to change this biotype on thick biotype that is characterized by a flat scallop with kinesis gingiva. The papilla is stocky and the teeth are often broad, rather square in shape. Many lectures and publications were done about the influence of mucosal tissue thickening on crystal bone stability around bone level implant. The initial vertical mucosal tissue thickness was shown to be one of the factors having impact on bone stability. The cortical bone stability is considered as the most important issue to prevent the soft tissue recession. The study was done on animals. If the mucosa tissue are thin to 2 millimeters or less, there is significantly more crest bone resorption after healing. While the implant placed in thick tissue had significantly less bone loss of 0.25 millimeters. The aim was to investigate how the bone level implant maintain the crystal bone stability. After thickness of the thin mucosa, the tissue with allogenic membrane. Let's show now the picture about this study. We can see in the left the thickness of the mucosa before surgery, and they placed the implant in this area and the allogenic membrane over the implant with the healing abutment. We can appreciate after healing the augmentation of the thickness of the mucosa after a few months. We can also appreciate that the bone is stable over time, and there are not bone loss around implants, and we are not you have a good stability, the soft tissue and the hard tissue around the implant. Within the limitation of this study, it can be concluded that if mucosal tissue are 2 millimeters or less, significant crystal bone loss may be expected. Naturally, thick mucosal tissue have a very good positive capability to keep bone stable. A second publication about the influence of vertical soft tissue thickness on crystal bone changes around implant with platform switching. The vertical soft tissue thickness plays a major part in the etiology of early crystal bone loss. This table shows us the difference between placing implantment with a thin soft tissue and thick soft tissue. You can see in the first study, when we place the implant in thin soft tissue, we can have more than 1.80 millimeter for bone loss against 0.22 millimeter of bone loss in thick soft tissue. It can be concluded that the platform switching does not prevent crystal bone loss if at the time of implant placement mucosal tissue is thin. In thick soft tissue, the use of platform switching implant maintained crystal bone level with minimal remodeling. That's why in this picture we have to have this thickness of mucosa around our Henning abutment, a very thick connective tissue and keratinoid gingiva around this. In operative time, we have to choose and to know what kind of gingiva we have, what kind of mucosa we have, and what volume of bone we have before implanting. In several times, we have an edentless area without major bone effect. And another times, we can see here a big defect between teeth, and we have a bone deficiency. We have to appreciate the volume of the residual bone and how we have to implant in this condition. First of all, we have to give a hard tissue remodeling before implanting in this area. We have also sometimes to have an extraction and immediate implantation in the same surgery. We have to preserve the volume of the bone and the volume of the soft tissue around the implant. We have to place in a good position our implant, especially in aesthetic zone. We have to place it in palatal position, and we have to preserve the area in the vestibular zone with implanting a bone graft in the alveoli. Yeah, we have many kind of surgeries to manage hard tissue before implanting or during the implantation. We have to know on our X-rays how is the volume that we have before implanting, and we have to know which kind of surgery we have going to done before beginning the surgery. In this slide, we can see many kind of surgery that we can give to conserve and to preserve the good volume of bone during the implantation. You can do the socket shield if we have not enough bone in vestibular position, and we have to let vestibular part of teeth to preserve the vestibular bone and place the implant in palatal position. Also, you can have a rich splitting. The, the benefits of this kind of surgery that you place your implant in native bone. It's so important to place the implant in native bone because we can have not big resorption when we place our implant in native bone. Sometimes we can't place the implant at the same time of the bone grafting. We have to recreate a new volume of bone before placing the implant. With horizontal or vertical bone augmentation, we can place a bone block with allograft bone grafting or a sticky bone or MPM bone. We are also create a new volume of bone with a 3D bone grafting or 2D bone grafting. After that, when we finish to create a new bone volume and a good bone volume to place the implant in the ideal or a good position, you have to manage soft tissue around the implant. Many techniques can be used will be used in this situation with a roll technique or a modified roll technique or vestibuloplasty technique or connective tissue graft technique or tunnel techniques. It depends what kind of soft tissue we have. We can also use the rotated pedicle vascularized connective tissue flap, or we can use the apical position flap or a free gingival graft. Ultimately, we have to place our implant in a good position with a good emergence profile. That's what every surgeon want to have a good health of implant and periodontal tissue. Ideally, we have to have a similar outlook between a natural tooth and implant. In second surgical time, we have to place a healing abutment. The healing abutment can be placed in the same time of the placement of the implant in the first time of the surgery if the implant is stable and we have a good primary stability of the implant and we don't have a big reconstruction of the bone around the implant. But in several times, we place the healing abutment in the second stage if we have a big reconstruction of the bone and we have to have a good stability of the osseointegration of the bone around the implant. The goals of the healing abutment is to guide the soft tissue healing and to prepare the emergence profile for the future crown. And to get a natural emergence profile will be more easily obtained when the diameter of the healing abutment approximates the cervical diameter of the future crown. They guide us to have a good profile of a future crown. You have to choose between different kind of healing abutment or dimension of healing abutment to provide soft tissue support. And we have to be sure that we have no tension on our sutures around the healing abutment in order to have a good healing of the soft tissue. That's why we can have this result after healing. You are ensure a good emergence profile. The shape of the emergence profile will therefore be the result of a compromise between biological and aesthetic obligations. Sometimes we have to change the dimension of the healing abutment for the aesthetic obligations. And we have to recreate a new papilla. This papilla will be created with soft tissue grafting, connective tissue grafting over the implant in the second stage of the surgery. We have to choose the good height, the good diameter, and the good form of our healing abutment. The height of the healing abutment must exceed the marginal gingiva by at least 1 millimeter. The aim is to prevent tissue growth above the pillar, but sometimes a shorter healing abutment of about 0.5 to 1 millimeter than the marginal gingiva for a better aesthetic result. We can use also some techniques for remodeling the soft tissue around the healing abutment. In this case, we do the roll technique and we create a new vestibular soft tissue. You can see in the right picture in this slide the good formation of vestibular tissue, and you can place your crown in good condition. This is the picture of the crown 1 year follow-up. You can also change the form and the dimension of the emergence profile with changing the diameter of our healing abutment. This you can change it for aesthetic obligation, as I said before, or for an occlusal obligations. Of abutment height and implant depth, position and interproximal peri-implant bone in sit with thin mucosa. The aim is to evaluate the marginal bone stability in bone level implant of two different definitive abutment heights. The conclusion is the placement of short definitive abutment may induce more bone loss than longer ones at two-piece implants with multi-unit screw retained restorations. And we pass now the benefit of the temporary crown. We have to recreate a good soft tissue around our implant. We have to create a barrier to avoid peri-implantitis in second time. The influence of our temporary crown is the acquisition of the mucogingival morphology around the crown and the retention of this morphology over time. We have a dynamic use of the temporary crown improves this gingival profile. Feroza and his team give a publication about the pink aesthetic score. 7.12 studies, 3 of them are directly related to the development of soft tissue during the surgery, and the other 4 points depend on the quality of the available bone volume and the result of the temporary phase of the emergence profile. During the surgery, we have to preserve the alveolar convexity, the soft tissue color, and the texture of the soft tissue. And during the temporary phase, we have to preserve the presence of the mesial and distal papilla and the alignment of color and the gingival contour, and to maintain a certain thickness of peri-implant mucosa. The shape of the emergence profile given by the prosthetic realization must not impair the good vascularization of the peri-implant tissue. A profile that is too concave can reduce the thickness of the peri-implant mucosa and eventually lead to a recession. We have to create a good temporary crown and a good condition around the implant and the good soft tissue to create a good environment to have a good emergence profile for our final crown. Sometimes we have to done soft tissue grafting around our pillar or our crowns to improve the quality of the gingiva around our temporary crowns and to have a good healing of our mucosa. For Albrechtson, the presence of peri-implant keratosis gingiva does not affect the long-term success of the implant if the maintenance is good. The development of soft tissue seems to favor the aesthetic and functional result. The keratosis and the attached gingiva, it means function to prevent a collapse of peri-implant tissue and to facilitate the taking of impressions and to have adequate height and thickness around the implant and to allow a clamp and a firm conjunctive attachment. This is the kind of keratosis tissue around the pillar. They preserve the pillars and we can have a good connective tissue to avoid peri-implantitis. We have, before starting to manage soft tissue, we have to manage, first of all, the bone deficiency. When we place our implant in this area, we have to reconstruct the bone around the implant. Sometimes in the temporary phase, we have a deficiency of periodontal tissue, and sometimes we have both. In the bone deficiency, we have to recreate a good volume of bone, and with placing the bone around the implant and to preserve the seat where the reservable membrane or not reservable membrane. The most important thing that we have an hermetic zone around our grafting to have a good result during the healing. When we have to change this soft tissue, you have to graft a soft tissue around the crown with connective tissue. In this case, we take a palatal connective tissue and graft it around the crown. This is the most important slide in this lecture. This is, we have to know this slide very in good in our mind. When we have in the left of the slide, when we have a thin mucosa between 1 millimeter to 2 millimeters of residual thickness of mucosa, we have to place our implant 3 millimeters under the bone. When we have 2 millimeters of residual thickness of gingiva, we have to place our implant 2 millimeters into the bone. We have to preserve the stability of the connective tissue around the implant and to avoid the bone resorption around the implant. And the right side, we can sometimes have 3 millimeters or 4 millimeters or more than 4 millimeters of thickness of the mucosa. We can place our implant only 1 millimeter under the bone or only on juxtacrystal position because we have enough thickness of mucosa around the implant and we can preserve the barrier between the oral cavity and the implant. The most important thing we have the 4 millimeters between the height of residual bone and the gingiva during the healing. This case was done 7 years before, and you can appreciate here the good position of the implant and the good stability of the bone around this implant, and also you can appreciate the good healing of the gingiva and the good situation of the crown. You have also to recreate a new papilla between the healing abutment during the temporary phase. Look at this recreation of the gingiva around this healing abutment. In this case, we can see here the quality of the gingiva, and we have to place implants in this area, and we have to appreciate the volume of the bone and the quality of the soft tissue around the future implant. First of all, we have to take out the epithelium of this gingiva before beginning the surgery to have in order to have only the connective tissue during surgery. We place the implant in the same time with the mini-invasive surgery, and we can see here the connective tissue that we placed into the cavity. That's the roll technique, and in order to create a new volume of vestibular bone, vestibular soft tissue, we placed the healing abutment and we give a suture without tension. We can appreciate here the volume of vestibular soft tissue around the healing abutment. And we placed the amovable prosthetic in this area without pressure on the healing abutment. This is the picture 5 days follow up the surgery. We appreciate here the new volume of the soft tissue in vestibular position. So we can see here different kind of implantations with 1, 2, 3, or more implant in the bone, but these surgeries will be predictable if we respect the protocol, if we respect the management of hard tissue, the position of the implant, and the management of soft tissue. We will have a good healing of our soft tissue and predictability of our protocol. And we can place our crown in good condition, especially when we have to place a crown in aesthetic zone. We have to create a new papilla during a temporary phase. You have to manage the vestibular soft tissue with soft tissue grafting with CTG or a free gingiva graft or another technique of grafting to recreate a new papilla between temporary crowns. And you can see here the quality of the soft tissue between the pillars. You can recreate a new papilla between final crowns. And look at this healing in the left side. We have a good healing around the implant, and we are sure that you have a good barrier of connective tissue between implant and the crown. In the case if we have a lateral ancillary agenesis, we have to create a papilla during the orthodontic step. You have to place a temporary crown to create a new papilla in this area. We place an implant with minimal invasive surgery, and we place our implant. You can see in the right side the position of the implant 1 millimeter under the bone, and we create a temporary crown in the same time of the surgery to preserve the papilla during the healing. You can appreciate here the emergence profile in the right side and the good healing of the gingiva around the temporary crown and the situation with the final crown. You can see here 1 year follow-up, the situation of the implant in the lateral incisor. We can't give the difference between a natural teeth and crown over the implant. In this case, we have to appreciate a volume of hard tissue and soft tissue. We can to appreciate this thickness of gingiva. In this case, we place the implant in native bone, and we place the sticky bone over the natural bone, and in the same stage we place a connective tissue to create a good volume of soft tissue during the healing. We use also a Palachi technique to create a new papilla between the healing abutment. This is the healing and the placement of the crown, and this is the healing 1 year follow-up. In this case, we place the implant in the good position, and we have a good stability of the implant, and we choose to place a provisional crown in the same stage and for creating a new soft tissue around the temporary crown. We can appreciate here a few months after that the good healing of the tissue around the temporary crown, and you can't give difference between the papilla between natural teeth and crown. We can appreciate here the good volume of soft tissue around the implant and the good placement of the pillar, and we can easily place our final crown in the good condition. In this case, we have two problems. We have a hard tissue deficiency, defect, and soft tissue defect. We have to manage the hard tissue first and the soft tissue in the second surgery. We have to create a good volume of bone and recreate a good volume of soft tissue around the implant. We extract the tooth, and we place the implant in the same stage, and we recreate a good volume around the implant with NPM reconstruction, NPM bone graft reconstruction. And I place PRF and growth factor over the bone grafting, and we close the flap, and we can create a new gingiva with soft tissue, connective soft tissue in the second surgery. You can look at the healing around this implant and the new reconstruction of the bone and the soft tissue around the implant in the right side. We place the crown after a few months, and you can appreciate here the difference before surgery and after the surgery. We recreate all the volume of the hard tissue and the soft tissue in the second stage. In this case, we have to recreate a good volume of tissue, the hard tissue, soft tissue, and papilla. You extract the tooth, and we place the implant in the same stage, and we place the provisionary crown. You can look at the left side, the new creation of the papilla after a few months. This is the picture with the final crown 1 year after healing. In this case, it's the same thing as before. We place the bone grafting over to cover the implant, and we place the membrane, the collagen membrane, and we ensure that we have a good sutures of the seat in order to close hermetically the seat. And you can see here the result of the healing with a final crown. In this case, we give free gingival graft during the temporary phase, and we create a new volume of the soft tissue around the pillars, and we place the crowns, and we recreate a new papilla between the crowns. In this case, we have to recreate a good volume of bone in lateral incisor agenesis. We have to place the good volume of bone in lateral incisor, and to place the implant in the same stage. And when we have a good stability of the implant into the bone, we placed the temporary crown at the same stage in order to have a good healing of the soft tissue. We placed in the final crown in the second stage in a few months follow. In this case, we placed the implant in the same stage and the bone grafting to recreate a good volume of bone, and we recreate a good volume. You can we cover the bone with the collagen membrane, and we create a new vestibular bone tissue, the bone tissue and the soft tissue. Look at the difference between the upper picture and the lower picture. We create a new bone. We lose a big volume of bone, and we create it around the implant. And the situations with the healing, we can appreciate here the new formation of the soft tissue during the healing, and we can compare the position of the papilla between natural teeth and the crown, and you can see as this is similar. We place the implant, the crown in this stage, and we can appreciate the height of the collars of the crown and the volume of the crown, and we can't give a difference between left side to right side. In this case, you can see the big deficit of bone uh, around the bridge, especially in central incisor, the 11. This bridge is not very good. You can see here. You have to change this bridge, and you can see here what's the defect that you have in the edontless area. We have to create a bone volume in the first stage and create a soft tissue volume in the second stage. You can appreciate here the defect. We give a surgery with a bone grafting, with placement of the implant and soft tissue management. In this step, we give a connective tissue in this area, and we create a good volume of vestibular soft tissue. You can see here the good healing after 1 week with a provisional or a temporary bridge. This is the bridge and the healing of the soft tissue after a few months. We can appreciate here the difference between the first picture and the second picture. The volume of the bone is changed, and we can here see that we have a good augmentation of the volume of the bone and a good health of the soft tissue around the natural teeth and the implant. We can see here the good health of our gingiva and the good healing around the temporary bridge. We place our healing abutment, and we recreate a good volume of soft tissue in vestibular position with a roll technique. And we can appreciate here the good healing of the tissue in the lower picture. This is the healing after a few weeks. We change the condition of the provisional bridge to don't give pressure over the healing abutment, to give a good condition of the soft tissue to heal in very good conditions. Look at the healing and the placement of the pillar. This is the pillar emplacement with the crown on the natural teeth, and this is the crown in position on the implant. You can appreciate here the good healing of soft tissue around the natural teeth and around the crown over the natural teeth and the crown around the implant. This is the final picture with the final crown in position. This is the smile of my patient. And this is the beginning of the surgery. This is during the healing of this case. And this is the final crown in position. You can appreciate here the good position of our crown and of our implant and our you have a good smile and a good profile of our patient. We want to have this result every time. Let's see now a little video about creating a new bone in difficult situation. We have 5 minutes to create heart tissue in this video. You can see here this video. This patient came with the lateral incisor was broken, and we had to extract it, and we had to get off the granuloma from the seat. You can see here the thickness of our flap, and the granuloma is very important. We are avoid the granuloma with our instrument and with the laser technique. As you see here, we decontaminate the seat with the laser, and we can't, in this case, place the implant in the same stage of this surgery. We have, first of all, to create a new bone in the first step and to place the implant 6 months later. In this video, we can see here to give suppleness of our flap in order to close our surgery. We have to close the flap, and we have to be sure that we are hermetic and we don't have to lose our bone grafting during the healing. You can see here this instrument. This instrument from Palachi technique, Dr. Shakroon. You can have this instrument to create a good suppleness of the flap, especially when we have to manage the soft tissue in aesthetic zone. Look at how we can obtain of suppleness of this soft tissue, this flap. As you have seen before, we have to close the gingiva in vestibular position because the teeth was broken, and we have to close the gingiva before placing the bone graft. We placed here a bone block, allogenic bone graft, to create a good volume. We fixed it with the screw. We will be sure that the bone block didn't move during the healing. If it moves, you lose this bone graft. We place the NPM bone grafting with allogenic bone grafting in the seat of the incisor, and we create a new volume of bone. We place also NPM bone grafting over the bone block in order to have a good volume of bone in vestibular position. We place the growth factors and the PRF over the bone grafting to preserve the bone and to avoid to lose this bone during the healing. We place also a collagenic membrane, a bioguide membrane, uh, over the bone grafting to ensure that it's hermetic. It will be hermetic, and we fixed it with two screws. And the most important thing that we have to close the seat. We have to know what kind of sutures that we can done to ensure that our flap will be not opened during the healing. The first suture will be done. It's a periosteum sutures, and you have to stabilize the flap before continuing continue suturing the rest of the flap. You can see the healing and the X-ray. In conclusion, if we have a case of success of our protocol to have a uh, good implantation and to avoid to have peri-implant in several times after the implantation, you have to prepare the hard tissue. It's a recipient bed with a bone grafting, and to be ensured that we have a good volume of bone around the implant. And we be sure to have an ideal implantation bearing and an ideal position of the implant. And we have to modify, if it's necessary, the biotype of our soft tissue thickness to create a new connective tissue in order to have a good volume of soft tissue around the implant. And in the temporary phase, we have to prepare the good healing and the good soft tissue maturation. In general, in definitive, if you respect the biology, it will be serve you well. So that's what I want to share with you this day. And if you have questions, we can I can answer you. You can connect me with this email address, and I will to thank you for your kind attention.
Thank you so much, Dr. Mohsin. It was wonderful presentation, and I believe that uh, dental surgeons all around the world have it was beneficial for them, and they learn a lot. Um, what I believe is that hard and soft tissue, they are just like good husband and wife. They complement each other.
Yeah,
If there is a discord, you end up in divorce. So
I,
a good soft tissue maintains the hard tissue, and a
yeah,
good hard tissue maintains the soft tissue.
yes,
So most of the dental surgeons who are practicing implantology in their day-to-day practice, um, I think we both agree to this thing that we have to tell them that they should learn perioplastic surgeries,
absolutely.
because if you do not know about the perioplastic surgeries, um, I personally say and tell people that forget about implants.
Yeah,
Don't do
yeah,
it. Don't do it. It's not good for the patient,
yeah,
because it has to be long-term predictability.
yeah.
Uh, what I saw in your pictures, um, um, you are using the stock abutments a lot. What about what is your opinion about the screw retained prosthesis? And another thing, have you ever tried? What about your experience with the tissue level implants? Because
Yeah.
then, when the tissue level is there, there's a lot of peri-implant seal which has been. Oh, because every time we take out the healing abutment,
Yeah,
the connective tissue which are getting the fibers,
yeah,
hemidesmosomes getting connected, they
yeah,
get dislodged,
yes,
and there is a healthy bleeding. But that the seal gets broken. But if you have a tissue level implant in the posteriors, the seal is intact, and that gives much and more predictable solutions in your implant dentistry, rather
yeah,
than taking it out and placing it back again and again.
yeah,
So that is why Nobel Biocare has come up with on-one abutments,
uh-huh,
and I believe, especially when I talk about India, Straumann has tissue level implants, and I have been using, and since I met Professor Daniel Boozer,
yeah.
I started liking these tissue level implants, especially for posteriors.
For serious, yes,
Yeah,
because you have to manage, you have to know how managing the soft tissue around these kind of implants in aesthetic zone. You have many. It's so hard to create a good soft tissue around these kind of implant in aesthetic zone. You can place them in the lateral or posterior position because we have not aesthetic obligations. That's why
yeah,
we placed a one level implant in aesthetic zone, and eventually the the other kind of implant in the lateral and the posterior zone.
Yeah, there is a question from one of our viewers that the practice of placing a CT graft, a connective tissue graft, at the time of placing a bone graft, don't you deprive the CT graft from the rich vascular bed? Wouldn't you do it either before implant surgery or at the second stage?
Sometimes when we have a good stability of the bone graft, we don't we give the bone graft uh, over the implant with the when we place our implant in a native bone, and we can have a good stability of the bone. We can also place our connective tissue in the same stage if we are sure that the healing will be conducted with the patient is very good, and we have to control this healing every week to ensure that the connective graft doesn't move and doesn't be lost during the healing, because the patients don't know what happened in their mouth, and we have to ensure our surgeries. And when we are not sure that the patient don't have a good maintenance of her healing, we have to choose two stages of surgeries. First of all, the placement of the hard tissue, and in the second stage, the placement of connective
In the
tissue.
soft tissue. Yeah. Yeah, because when we do the CT graft augmentation in the second stage, it is, I believe it is more predictable, because when you do a partial thickness flap, which is apically advanced, and then sometimes you do it FGG, or most of the times to enhance the thickness you cover it with the CTG, especially in anterior aesthetic zone. I love doing the PTCTG, pedicle
Yeah,
tunnel connective tissue
yeah,
graft.
yeah, yeah,
And Snejana Paul has come up with this IVON technique, modified IVON technique. So it is just a modification of the PTCTG, where we use the tunneling from the palatal side and
yeah,
going back into the buccal aspect. But here in modified IVON technique by Snejana is like they give a incision on the palatal side, and then it becomes little easier for the beginners also.
yeah,
Um, Another thing which I have found, which Professor, first thing which I like is, and I would like to stress onto that point, is stress is the biggest stress.
yeah,
The soft tissue doesn't should not be under stress. The hard tissue should not be under stress. And
yes,
Professor Palachi stresses onto this point a lot. And even
mhm,
Professor Shukroon says that
yeah,
even your implant should have a stress-free zone from the coronal aspect or to
yeah,
the crestal bone, because it is very sensitive. So it goes into
recession.
recession. And we have to think about the buccal bone plate, which is a great study by Daniel Boozer and Vivian Choppy, that if your buccal bone thickness is less than 1.8 millimeters, so
Yeah,
critical thickness has to be around
yeah,
2 millimeter, and
mhm,
then you can decide your placement of implant accordingly, where you are going to get. So the CBCT assessment is very important, because if it is less
yeah,
than that, they have found in long-term study, the CBCT comparison, that you
mhm,
may end up having 7 mm vertical bone dehiscence
yeah.
in the
Mhm.
cases if you have not thought about it.
Yeah, as I said in the last slide, if you respect the biology,
Yeah,
they give you around you, okay? Okay, we have
uh,
to respect the biology.
Yeah. Another thing which I have seen, Professor Dong Seok Son is doing a lot, and even I tried a lot about that, and I get a lot of volume of soft tissue on top of it. When I place my implant, little subcrestal, and then I place a short 2 millimeter gingival healer on top of it, and then I close the soft tissue on top. So it
Mhm,
gives a tenting effect and creates a lot of soft tissue volume. And then after 16 weeks or 14 weeks, I take out gently that gingiva healer and
mhm.
place a longer one, like 4 mm, 5 mm, and then I
To
create
create,
a emergence.
create a new volume of the gingiva.
Yes.
Ah,
So
mhm,
what happens? Then you get an emergence with a beautiful volume of soft tissue around.
mhm,
Because in the first stage, I close the soft tissue on top of the implant, and on top there is a 2 mm GH, and then close it on top.
mhm.
So that also, this is one technique which tenting effect, which Professor Dong Seok Son has come up with. This his he has given a special name to that. But I normally it's something like changing your bone level implant into a tissue level like kind of
Yeah,
situation.
no, yeah.
Yeah, and it gives a very good bone volume. And
Mm,
Palachi technique always tells about the uh, reducing the pressure of the soft tissue,
mhm.
and that is great. So uh, we just got a message from
From
um,
Henry.
uh,
Henry.
Henry, Dr.
Yeah.
Henry Dijesh.
Yes.
So so I think from the audience side, we do not have any other question. Um, but I will recommend, as you have recommended, that soft tissue brushing technique by Professor Shukun is
Yeah, it's good.
fantastic.
Fantastic. Yes.
Yeah, fantastic to give you a stress-free closure.
Yeah.
And Palachi technique is very important, because then that kind of tension which you get if you are not doing the Palachi, that will not give you a very good soft tissue onto the buccal
And
aspect.
the most important thing, Sandy, that
Yeah,
when we use this technique in order to have a good elasticity of the flap, we
yeah,
have to give a good suturing after that. If you suture the flap, you join only it's not very good. We have to place to make
the
first suture
keratinized.
into the flap, and you have the place in palatal position to stabilize the flap before, and you can continue suturing.
Last thing I would like to ask you, in your video, you placed an allogenic bone, block bone, and you screwed it, and
Yeah,
then on top you used sticky bone.
yeah.
What was the material, the biomaterial which you used as a sticky bone? Because
It's
I,
also allogenic bone.
it is also an allogenic
Well, it's the same allogenic bone inside the seat between
on
the bone block, and on top to have the same bone in the
top. I would like to discuss onto this, because um, I ardently follow Professor Daniel Boozer, and
yeah.
in his contour augmentation technique, what he does is he packs up the xenograft, the bovine bone,
Mhm.
uh, and he says that to maintain the scaffold and a long-term stability onto that, that bovine bone is much better, because it maintains the volume, it maintains the scaffold, and it will remain for years. Like he has follow-up of almost 25 to 30 years, 25 years.
Mhm.
So because allogenic bone tends to resolve.
Allogenic one, yeah, yeah.
Yeah.
That this technique, I use it and I combine between allograft and bovine graft in lateral position in lower maxilla. Now
Hmm.
I practice this technique, and I have a good result also. But here I I can also use the bovine
On
graft
top. On top.
on top. Yes, I
Yeah.
can, but I have enough allograft, and I use it in this surgery also.
Yeah, but when you are thinking of using allografts, I believe it should be more of cortical nature, so that it resists the resorption.
Yeah.
Less cancellous, more cortical
Mhm.
particles. Then I think it makes a lot of sense for that. So thank you so much for wonderful presentation, Dr. Mason, and I'm so happy that I'm back here, though I was not in condition to come down because I'm undergoing a lot of stress because I lost, as I told you, that I lost my workplace of 20 years.
Yeah.
So I have to shut down and I have to build up a new setup, new clinic for me.
Right.
But since you were there, I made it a point that I have to host him because he's a wonderful friend of mine and I know him personally. So thank you so much for being with us, and we'll be back again with wonderful presentations. And we are with Kianor Shah and the whole team. We are working hard to bring in best in the dentistry, presenting it in front of the whole world. Thank you so much, and namaste.
Thank you for you, Sandeep, and
Yeah,
good luck for your clinic.
thank you so much. Thank you
Thank
so much.
thank you.
Yeah, ciao, ciao. We